he said this, he wrote this at a time before we had embarked on healthcare reform. I think because in this country we at least pay lip service to the fact that everyone has a right to education, or has a right to protection under the law. And until recently, we did not say that everyone has a right to health care. So I thought in the spirit of stories, I'd tell just 2 stories about families I worked with and 1 story about myself. So that the first was that as I embarked on this work of doing family talk, the first family I saw, this is how your friends help you. The first family I saw, I said, I'd like to see a family where there's a parental depression and there's not a lot else going on, and I can try to think whether I can help these people. So on the first day that we saw this mother, in the evaluation session, she said, I'm going to kill myself right now today. So we stopped the intervention, took care of that, and then I worked with her, and what she taught me over months was that despite that illness, she was an extraordinarily committed parent, very deeply aware of her kids, and very deeply concerned about how to help them. And we were able to have a dialogue, have a conversation, and help them. So it convinced me that parents can be very effective parents despite depression. And we can reach people who are parents, or are teachers, or caring for people, for children, by aligning ourselves with those resources. And the second was a boy I took care of who had a terrible experience. His mother committed suicide in the middle of a manic episode, actually when she was hospitalized. And he was brought to me at about 7, and he'd been pacing around and talking about death. And, probably the smartest thing I did with him was to recognize that he did not have mania and did not need medication. But I talked with him, and he calmed down and moved on. I saw him intermittently over quite a number of years. He put within himself the positives of his mother, but at each crucial point in his life, when he transitioned from grammar school to high school, when he had his bar mitzvah, when he went to college, when he had his first girlfriend, he had to renegotiate and rethink and re-understand anew what both his mother had meant to him and the loss of his mother, and many other figures in his life. He had a very loving father, a loving stepmother, and other connections. But again, it taught me that we need to think about the long term and how to make sense of things over the long term. And finally, myself as a very young man worked in the civil rights movement. And then when I was at Mass General working with Dan Eisenberg as a resident, I said the healthiest people I've ever known are these civil rights workers, and he said, take whatever time off you need and try to understand them. So I went back to the South and interviewed these people about how they'd been in the South and in the movement for more than 15 years. And they really said 4 things. First of all, they were able to be very angry about the injustice in the court. Remember that many lives were threatened, a number of people were killed. It was a very dangerous time, and they were able to be very angry and yet keep working. Secondly, they were very much activists and doers, registering voters, starting Head Start centers, running for office, and not passive or overcome. Thirdly, they had extraordinary human relationships and were deeply committed to them. And finally, they had an extraordinary understanding of themselves, self-understanding and shared understanding. They were able to say, I am here, I know why I'm doing this, and I choose to do it. In other words, they were very much part of a narrative that they saw as leading somewhere. They all had powerful figures from their past that confronted injustice. And so I came to think about those dimensions of resilience, and that's informed all of the work that I've done since. One of those historians was John Lewis, who's now the congressman from the 5th District in Atlanta, and he said, after what Martin Luther King said, what he did, you couldn't be alone again. Being in the movement makes you part of something really important. So with that as an introduction, then, I think that as we think about evidence-based practice, we should be thinking about strength and resilience. In the Institute of Medicine report, we talked about mental health promotion, mental health prevention. Prevention aims to enhance individuals' ability to achieve developmentally appropriate tasks and to have a positive sense of mastery of that plan, and to strengthen the ability to deal with diversity. Joan had mentioned the fact that 50% of adult disorders have their onset by 14, 75 by 24, and first symptoms occur 2 to 4 years prior to diagnosis. If we're either going to do early intervention or prevention or both, we need to be thinking very early. The common risk factors for multiple problems, and we need to get a sound understanding of risk and protective factors. And this is just a diagram from the Institute of Medicine report that shows across the top developmental epochs, across the lines, interventions that are valuable at different developmental epochs. So care prior to pregnancy, good perinatal health, good care during pregnancy, home visiting, center-based care has a great deal of value in the early years of life. In many of the European countries, center-based care is subsidized and available for free for everyone, and there is home visiting for everyone. So, but those are very valuable interventions. When we move into school, there are interventions that are both teach social and behavioral skills, do academic interventions, parent skills training has an extraordinarily strong knowledge base and evidence base. As we move into adolescence, there's evidence about the prevention of depression, the prevention of schizophrenia, and the prevention of substance abuse. And across the bottom, 3 important areas: preventions focused on specific adversities, bereavement, divorce, parental psychology. Lots of very powerful things we can do. Secondly, interventions that strengthen community structures are really important. And finally, policy interventions. The generic features of preventive interventions, they reduce or minimize toxic biological and psychological processes, richly reinforce self-regulatory and pro-social behavior, and teach social skills and values. And I'll come back to the issue of values. And they foster acceptance. Again, family-centered preventions have a very strong evidence base. Depression risk and effective parenting in particular. There's evidence about the prevention of first episode of schizophrenia. We'll hear about that in a bit. A central theme from the Institute of Medicine report. The scientific foundation has been created for the nation to begin to create a society in which young people arrive at adulthood with the skills, interests, assets, and health habits needed to live healthy, happy, and productive lives in caring relationships with others. Abraham Lincoln signed into law the foundation of the National Academy of Sciences and the Institute of Medicine in 1863, before the great battles of Vicksburg and Gettysburg that turned the tide and preserved the Union. And it was very much with the idea that science serves the public interest. That's very much the idea of evidence-informed prevention. And as I said earlier, the science is very much on our side. The science has gotten much better, and we really have a very strong evidence base in which to begin to think about how to help families. Implementation was one of our major recommendations. It needs to move to effectiveness trials, and it's complex, and the role of the community is vital. I thought, again, I'd say just very briefly something about family talk. In our work, we think about conversations at 4 levels, stories at 4 levels: the individual, the family, the caregiving organization, and the larger community. And if we think just from a public health point of view about risks for depression, there are a series of risks that are specific to depression in the sense that they increase the likelihood of episodes of major depression, having had a prior depression, bereavement, depressive cognitive style. That would be Eeyore in Winnie the Pooh, okay? And then risks, general risks, meaning exposure to trauma, poverty, social isolation, job loss, unemployment, family breakup, loss of communication, dislocation, and historical trauma. That comes from work we've done in Native American communities. All of those lead to higher rates of depression, documented in empirical studies, but they lead to higher rates of many other disorders as well. That's why they're non-specific. And I think we would probably be able to say that we need to significantly diminish exposure to trauma, and we need to significantly change the distribution of wealth and cut down poverty. So that's sort of how I think about that from a public health point of view. From the standards of science, using meta-analytic techniques, at the beginning of the 21st century, major depression can be prevented. Kuipers did an excellent review, and the evidence suggests that 22% of major depressive episodes can be prevented. Sally Mary did a comparable review for the work on children and adolescents, and would have similar findings. In the Institute of Medicine report that we did, again, lots of evidence about promising interventions, improving depression in the parents, targeting vulnerability in depressed parents, improving the parent-child relationships, and using two-generational approaches, and broader preventive interventions such as Head Start really have a lot of value for depressed parents. There may need to be extra outreach. And again, to talk about family talk for a minute, we built this on a resiliency framework, the characteristics of resilient youth growing up in homes where there's depression, activities, relationships, and self-understanding, knowing that the parent has an illness and they're not to blame, and similarly, in terms of the parents, a commitment to parenting, and openness to self-reflection, and a commitment to family connections and growth of shared understanding. And one person that I interviewed at length said this about growing up in a household with a depressed parent. First, you should explain why people get depressed. You really don't know what it is, and if it can happen to you. You don't know why your parent feels that way. You don't know if you're going to feel that way yourself, or how to manage it if you do feel depressed. If someone has a disease, you want to know how he or she got it, and how you can prevent it from ever happening to you. Otherwise, you have fear. You can't trust something that doesn't have an explanation behind it. So that was sort of the impetus for developing Family Talk, which is essentially leads to a family conversation in families where parents have wrestled with depression. It's a strength-based program, a series of meetings with parents, children, and then a family meeting. Follow-up, it's designed to complement treatment and work collaboratively with others in the healthcare system. And again, the individual interventions modules are taking history, doing psychoeducation, no one's to blame, this is no one's fault, seeing the children, sitting with the parents to plan a family meeting in which they are able to have a conversation about how the family will overcome depression. Planning the family meeting, holding the family meeting, doing a follow-up 1 week later in order to make sure that everybody's okay, and then longer-term follow-up. And we've added an optional module that talks about basic skills. And I would say two things about this. One is that I'm doing this work. My wife and I have been raising 4 children, and I think speaking both as a mental health person and as a parent, if you're going to have a conversation with your kids about something that's important, you have to master it yourself. You have to think about it, you have to figure out what you're going to say, and you have to take the actions that are necessary to show the children that you're serious. So I think the power of this intervention derives from mobilizing the resources of the family in an effective way. I think the second thing is, we would say very much that it's not the abstraction of depression, it's what's actually happened in the family, what's changed, what's different, and that's what needs to be talked about. And that sort of puts things back together. And I'm very pragmatic. So in terms of how to do a family meeting, these are some things I heard for parents, but pay attention to the timing of the meeting, gain commitment to the process, begin by identifying specific concerns and addressing them, bring together and knit together the family history, plan to talk more than once, and draw on all the available resources to get through depression. 4 key objectives: reassure your children you'll be okay and the illness will not overcome the family, emphasize that no one's to guilty or blame, speak to the positives, and present knowledge about depression and treatment.